Good afternoon. We're recording this session, so I'm speaking into the microphone for the videotape, not so much to amplify my voice here. But it is my pleasure to introduce Valerie Grdisa this afternoon. Dr. Valerie Grdisa is no stranger to the Faculty of Nursing. She's one of our very own adjunct faculty members, and many of you I know have heard her speak previously. So she's recently relocated about a year ago now back to Ontario, and we're just delighted to get her back to Calgary for the afternoon today. She has a really distinguished CV, a very long list of accomplishments and career challenges over the years. She has done clinical work as a nurse practitioner. She was an academic at the University of Toronto as lecturer and director of their nurse practitioner programs. She has a long track record of innovating in healthcare systems and leading implementation of nurse-led clinics, consulting work with KPMG on health systems change. She was most recently former senior nursing advisor to the Deputy Minister of Health here in Alberta, and now currently RNAO Director of International Affairs and Best Practice Guidelines Center. So we're going to hear all about that today, the newest reinvention of Dr. Grdisa. Through all of these roles, I think what's really remarkable is Val has this real intense passion for evidence-informed nursing practice, and that shows up in all of the work that she's done, always really been skillful at interpreting and adapting evidence from research to practice. And it's not a surprise then that she has landed with this initiative with the RNAO. But she's here today to help us understand this internationally recognized initiative that RNAO has spearheaded so that we can consider potential ways that we might want to capitalize on this resource base, and that we might want to contribute to this snowballing process that is going on globally under Val's leadership, because I think there are opportunities for us in both teaching and research if we can find ways to take up some of these ideas. And there would be opportunities for scholarship and research, I think, across the faculty, for instructors and researchers as well. So many of you I know are familiar with some of the RNAO guidelines. I know some of you have used them in your teaching and have adopted them in your the undergraduate curriculum. So we're really interested as a faculty in trying to identify where some of those points are, where people are already familiar with the best practice guidelines from RNAO and are using them. And we're interested in just kind of seeing who's here in the mix, who might be interested in helping to lead up some of these activities heading down the road. So a real exploratory afternoon ahead, and I'm sure it'll be interesting. I'm just going to pass the floor to Valerie. So microphone.
I've got it right here.
Okay, great.
All good? Okay, so absolutely delighted to be here. I'm actually here as your colleague, so take it easy on me. I know I've settled back in Ontario, but and always delighted to be in Alberta. I was actually here last weekend for a wedding for one of my Alberta health colleagues, so every time I arrive, I post tons of pictures of my journey around both Edmonton, Calgary, and into the mountains. So this really is our opportunity to have a strategic conversation, but I am going to kind of go through a little bit formally the best practice guideline program, the cycle, what the BPSO movement's all about, and then the type of deliverables academic institutions are expected to meet to become a BPSO. And I really want you to stop me at any time if I'm not making sense, if you want to hear a little bit more about the program, a specific component of it. And there is actually, and it's sort of against the way I operate, but not in terms of busy slides for any of you that have come to any of my presentations, but there's a lot of slides, but I do want to just give you a snippet of the program and the extensiveness of it. So just as all of you know, and I think it's so important for you to understand, although this is embedded in a professional association, it's actually a ministry-funded program like any other ministry-funded program. And so, it could be, when you think about a regional health authority, HQCA, like that's exactly what this program is. And so we really are arm's length to the actual professional association side of the organization. It's just that RNAO had demonstrated in the 90s to the government at the time that they could actually lead some innovative strategies on behalf of the profession, and then the funding started flowing. So I just wanted to get that out there. And we do only represent RNs and MPs and obviously students. There was a separate professional association for RPNs, which is LPNs in the East. And the Best Practice Guidelines program was established over almost 2 decades ago now. So does anybody know when it was established? Anybody in the room from the East? A few of you have a sense? Yeah, not that early, but close. It was actually 99. So literally the Minister of Health at the time, Elizabeth Whitmer, was nursing friendly, and she was a PC minister, and she felt that as there was restructuring going on in the province, that nursing was being a little decimated. And so they wanted to make sure that we maintain that middle leadership of nursing, and also that we continue to integrate evidence into practice and make sure that there was nursing-led quality improvement. So the funding started then, and I don't know, you know, all of you, and I'm wearing my old chief nurse hat of a ministry. Like, when you think about, we're going on almost 20 years of year-over-year funding, which is pretty remarkable for a nursing program. It doesn't happen necessarily across the nation in the same way. So these were the original goals of the program: to reduce variation in nursing care, get that research evidence into practice, convey the knowledge base of nursing. We all know that sometimes our work, because it's not measured in the same way, say, as our physician counterparts, that it's invisible. And we wanted to really start to demonstrate the impact and value of evidence-based nursing care. Assist with decision-making, obviously research. We have had opportunities where we've actually stopped interventions. So some of the debriding interventions we were doing in the 80s and 90s were stopped based on the evidence. The ways that we manage falls in terms of bed height and side rails, things like that, that seem so fundamental, but the evidence demonstrated that there was a different approach. Obviously reduced costs, and a lot of this work has informed nursing and health policy. So although we, you know, have our funding at a provincial level, from the inception, it has always been a goal to spread from local to national and international. And we know that how many of you are actually have you used the BPGs in your career? Okay, how many of you are accessing them for your academic responsibilities? Okay, great. So this is the program, and it's important for you to understand the rigor of the program. The top is guideline development, so there's a team focused on that, and I'll get into that in great detail. Then we have a whole implementation science team and strategy, and it's focused not only on BPG implementation and spread, it's also some subpopulations like addiction and mental health and tobacco intervention, and I'll briefly mention those. And then we've, over time, only in the last 5 years, developed a more rigorous approach to evaluation and monitoring. Most of the work was, you know, more case study based, and now we're starting to implement and integrate quantitative and qualitative research and or quality improvement evaluation, because sometimes I kind of sort of have been pushing at the CEO that are we really doing research just yet, and should we be? And that's some of the conversations we're having. So really we work with, whether it be the academic institutions, researchers, whether it be graduate students or programs of research, and there's one in the University of Ottawa I'll get into more detail about, and or independent researchers from across the globe. And we actually have a research foundation now, or fund, that anybody can pull on. So I'm not going to get into this in great detail. I just want to let you know that there's really, and it's important, I think, from even a nursing perspective to understand the breadth and depth of the program. But we have the research team that's led right now, an acting role of the associate director by a PhD prepared nurse. We have a long-term care focus program, so we have 14 regional health authorities. They're called LHINs in Ontario, and we have a nurse that was a director of care leading that. We've got funding specifically for mental health and addictions and tobacco intervention, so we have someone leading that program. Then we have the implementation science team, and then we have the evaluation and monitoring team, and we have sort of leaders at each level, and then I'm sort of overseeing the international and national program. So let's get into guidelines. Does anybody know, without looking at your folders, how many guidelines exist? Take a guess. Over 10, 20, 30? What do you think? There's 53. And I'll show you the list in a bit. So I think it's really important from a nursing perspective that we understand this, that first of all, they are nursing-led, but we have, as the years have gone on over the decade, we first of all went from having predominantly all nurses on the guideline development teams, the panel of experts, to a blend of nurses and others, to now probably 52 to 48 split between nurses, interprofessional colleagues, researchers, and now patients and families are in every single panel, which is really important. And I'll give you an example. At Trillium Health Center, I was at a Nursing Week event earlier this year, and a man was talking about how the end of life BPG, that was the last hours and days, actually helped him prepare because he had been on the panel. So sometimes we, because the nurses had it on the floor and he picked it up and started opening it, and he lost his wife. So we've actually established a public and patient engagement council to ensure that they review all the BPGs before they go out to utilization by nurses and others. So they're systematically developed. We do double-blind systematic review, obviously, and based on current evidence. And we use 2 different methodologies. We have the agree-to appraisal that we implement, as well as we use grade and grade circle, because obviously this is, much of what we do is not quantitative as nurses, and you can't evaluate it in a quantitative manner. So we've implemented the qualitative component of grade to ensure that we get the best available evidence to inform nursing. So how it works is, we've aligned with grade methodology. So grade is grading of recommendations, assessment, development, evaluation, and grade circle is confidence in the evidence from reviews of qualitative research. So we integrate both into BPG development. Just to do a check-in, is this the right pace for everyone? Okay, good. So, and we also follow the agree-to standards, which are set by the National Guidelines Clearinghouse, which is an international arm. And it's very, that includes all of the information provided here. But I think what's important to understand is as more and more guidelines come up, because RNAO actually was one of the first, and especially for nursing, there's other professions, including our physician colleagues, that have started to implement guidelines, whether it be in associations or as private businesses. So there continues to be an alignment interprofessionally around the quality and the rigor and the strength of recommendations. So we adhere to those sort of criteria. So just to quickly go through the BPG development process, there's usually topic selection. I'll share a few ways that topics come up in a minute. We have a panel of experts. For example, right now, how many of you know Dr. Grdisa Cummings at U of A? So she's on our violence, harassment, and bullying BPG that was launched earlier this year. And there's always opportunities, and how it works, if you're on the panel, you actually are considered either an industry expert or a research expert in the topic area, and then you join the panel, and outside of 2 live meetings, everything's virtual in terms of your review and stuff, but you do get 2 live meetings in Ontario, and that's funded, like all of that activity is funded by the government. I talked about the systematic review, recommendation development, there's internal peer review and stakeholder review, and then publication. And the systematic review has the following components that you're also familiar with. And then we have, for the recommendation development, we have, based on the evidence summaries, we actually have these narrative summaries, and we draft recommendations, and those go out to the panel of experts, and then we do a modified Delphi approach to ensure that the recommendations actually, we can hone in on the ones that everybody agrees to. This is when the in-person meeting happens, the second one, because we come together, and anything that doesn't hit 80%, we vote on and have conversations about and align and change. And then we draft the guideline. And the process usually takes anywhere from 13 months to probably 16 months, depending on our startup and the quality of the evidence and or the depth and breadth of the evidence. So for instance, right now we're doing one on supervised injection services, and there's not a lot of evidence related to that. So that required more panel expertise and some site visits to BC Insight, et cetera. So really, when we're thinking about the guideline, it involves leadership by nurse researchers and defining the questions. So usually the co-chairs is a nurse researcher or considered practice leader that's got some type of research experience. We have a coordinator, we have a health science librarian that we contract out, and we've got about 4 of them we work with. I've talked about the panel. They come in, they help set the research questions and the approach and the strategy and the scope and focus, and then they come back when the first build of the recommendation statements are done. And then we have the peer and stakeholder reviewers and the editor publisher, and they all look something like this, and I'll leave them just for you to see. There's a myriad of them. So they are up on the website, so if any of you haven't seen it, there's what they look like, each single one of them, and then they have the bibliography here, and then other attachments that are related, because sometimes we'll actually get funded. So for instance, for this particular one, government actually wanted us to have some specific content related to Indigenous peoples, and so we got a little bit of extra money for that to ensure that that was relevant to that population. Each guideline includes a patient education fact sheet. It's a 2-page fact sheet so that the nurses can actually talk to their patients, you know, maybe if they're, especially the nursing students, when it's a nice kind of like executive summary at a layperson level, which is great for when you're doing some patient teaching. The nursing order sets I'll get to in a little bit, and then we have this data system that's been established since 2012, and there's about 140 data elements. So there's the 53 practice guidelines, and we've categorized them into 4 categories. They're foundational, population health, clinical, and system healthy work environment. And then we have implementation toolkits, and I brought one as an example. And this was actually created in collaboration with Causin, and this is and you can just hand it out, the mental health resource for educators, because just in terms of embedding mental health and addictions curriculum into your programs. The way they were designed, and this was almost from the beginning, is that, you know, we can put the best possible practice recommendations in place, but if we don't actually have them with the education and or organizational policy, then we might not achieve that. So we actually do lit reviews when we do the systematic reviews in all 3 areas. And so we have research questions related to each area. Here's the list, just for those of you who've never seen it. So in the foundational, we've got the I'm not going to go through it, but you just to kind of have a sense, intra-professional collaboration, which is important in this day and age, nursing leadership, client-centered learning. And they're actually in order of dates, because as of actually July this year, BPGs will only be posted on international websites like NGC if they're less than 5 years old. So they have to be within their 5th year, so you really have 6 years to renew within a calendar cycle. So we're just starting to make sure we catch up, and or we're actually retiring some. It's so that they will not actually leave our website, but we're not actually concerned about them being not on the NGC website, because there's likely when we retire ones, it's because there's actually better resources out there, and we're not going to duplicate. That's one of our decisions. Right now, we actually are working on 2. This one has been, we have a rainbow nursing interest group in Ontario, which is the LGBTQ community. So they've been sort of lobbying for us to create a guideline in terms of supporting nurses and their colleagues to work with that community. So we've launched that. The Safe Injection Sites is literally in its first full draft, and that will be launched. And as you know, like all of us are experiencing this horrific opioid crisis, we felt it was important to have a nurse-specific guideline as they're working in the communities. And then I'll go all the way down, and we have, and I don't know where it is here right now, but we have breastfeeding best practices for nurses in 2003. Now we're actually just working on one that's more about sustaining breastfeeding rather than initiating. That one's more focused on initiation. And crisis intervention's about to be published. I just did the last review. And then we have a plethora of clinical ones, and the ones in the orange are being highlighted here. End of life, ostomy, and oral health. And in Ontario, like here in Alberta, you know, there's some mandatory requirements within our long-term care homes. And for us, you know, ostomy care and oral health care are mandatory. So they'd come out of date, and so we're like, well, we got to get them back up to the top of the list, because we're not actually giving our nursing colleagues the best available evidence. I got to keep going, and this last system and healthy work environment. See this one here, adopting e-health solutions, and I think, is it here? If not, no, it's not here. That's one of our latest ones. That was actually funded by Canada Health Infoway in a collaboration with Ministry of Health. So some of these are actually co-funded because it's an ask from sector. And even this one here, practice education nursing, that was a collaborative one with Causin and Coupin, similar to NEPAB here in Ontario, or in Alberta. This one here is the one I just mentioned, Grdisa is working on with us, and so it's kind of replacing both of these here. So am I going at the right pace for you guys? Okay, good. So then on to dissemination, implementation, and sustainability. So everybody's like, oh, there's evidence everywhere, you can pull from everywhere, and you're kind of right, but there's really, honestly, in nursing, there's nothing like this real list of, you know, nursing-specific guidelines focused on nursing. So there are guidelines out there, you can go the NICE guidelines, but they're not as focused on our profession. And I do believe, you know, like Diane highlighted, I seem to have a 3 to 5 year cycle on everywhere I work, and then I either get bored or they get bored of me. No, and so to me, like, here we have a government in Canada funding the creation of guidelines by an interprofessional team with patients and families. Why aren't nurses across the nation using them systematically to demonstrate the impact and value of high quality nursing care. And that's kind of what motivated me to go into this role, is that I was literally, and I'm now, you guys, some of you have heard me speak about my life in Alberta Health, but it was probably the biggest eye-opening experience for me to realize how hard it is to fight for the value and impact of our profession. And so this program is demonstrating it every single day. And you know, I was a nurse for much of my career in Ontario, and yeah, I'd pick up the BPGs when I was a clinical nurse educator, integrate them into a course. This was one of my many readings, but never really realized how actual transformational it was that a government has been funding a profession to actually build evidence to advance itself, right? So, and this is sort of where I think, when I think of academia, must really pay attention to in terms of its role, because the implementation program is quite robust, and you know, really, I do believe nurses are at the coalface of patients, families, communities, and we are the ones that are implementing some of the strategies. And I remember early on in my senior nursing advisor role here, Deb White and I were at a meeting around the strategic clinical networks up in Banff. It would have been in 2014, and her and I happened to be sitting beside each other, and all of a sudden a presentation occurred about one of the SCNs, and all of you know what the strategic clinical networks are here in Alberta, right? And it was about pre-op teaching by nurses, and yet it was being presented by the surgeon, and now this is being taped, so I'm always like putting myself at risk. But I started to get really antsy, and I'm saying to Deb, why isn't a nurse up there presenting? Or at least standing? Okay, fine, if it's too short a presentation, why aren't we like showing that we're an interprofessional team? Because we're actually having another profession present on our interventions and present on the incredible impacts of our interventions. But most of the people in the room actually did not get it, because it didn't say pre-op was nursing care. It would have been, and there was I'd say at least about 10% of the people there were lay people and or patients and families. It sounded like it was a medical intervention, and I actually was flipping out. So I had to put up my hand and ask him to specify actually what the intervention was, and are there any nurses in the room that actually were involved in this initiative? And there was someone on that SCN, and so yay for that nurse, right, and that leadership. And I think that was the day the ex got on my back, right? Too empowered a nurse. But anyways, when you think of what it is we do, and there's over 50% of us that are of all the workforce, right, in every single jurisdiction, and the impact we're having, and how do we actually demonstrate that impact? So we're using a very proven toolkit, the knowledge action toolkit. We're going to update it shortly, and so we have a toolkit that embeds everything you need to do. And honestly, and Diane did mention that I was at KPMG for almost 5 years. And it's funny, because I actually went to consulting to go, what is this thing? I'm sitting in management roles, and all of a sudden you have a new consultant. Every 2 months there's a new private sector consulting firm. And it was sort of, for me, post-PhD, I thought I might do consulting for a year or two until I found my way and where I really wanted to land. And I almost lasted there 5 years. But really, if you look at what consultants do, consultant agencies, is they're really they start you going, and then they run away, right? And so that's why there's so many failures. What is it? Only about 15% of action holds, because it's not the true implementers that actually take the lead and implement it into their work. So this, to me, when I open this toolkit, this to me looks like, for those of you who've been involved in lean process improvement, it looks like that toolkit around doing your gap analysis, determining where you fall short, developing an action plan to address those gaps, implementing some change management strategies, evaluating the impact of your efforts in real time, all of those things you do regardless of how we name it. So in Ontario, and I'm going to go into the implementation methodology. How this works is we actually have the Champion Network, and I'll get into this in more detail, but we actually educate thousands of nurses on how to become change champions. So across the globe now, there's probably, I'd say, about 30,000. But in Ontario, there's about maybe 15 to 20,000 over the 20-year cycle, where they just learn the skills of change and driving change and leading change in their practice environments. We also have, and this is something, depending on how things settle here in Alberta, we actually have an advanced clinical practice fellowship. So we have nurses that come in, they get a $12,000 grant that goes to their organization to free them up to do a change project, a quality improvement project. Some of them have very rigorous evaluations, some of them don't, because it could just be implementing a new strategy, but they don't have time for the evaluation if it's a whole of organization, but it gives them the evaluation metrics, versus some might be on a unit, really specific, and then it helps them maybe with their master's and or PhD. I'll get into the nursing order sets in a bit. We have BPG apps, and you have the little app thing in your handouts. We have RNAO communities, which is just you go into our website, and if you're, say, focused on children and youth, you can go into that area, or addiction, mental health, and have a conversation with like-minded nurses and others. And then we have tons and tons and tons of free professional development and some paid, but most of it's free. And as we've gotten more and more sophisticated with our internet, it's free to everyone. And so it's webinars, e-learns, and it's just literally you log in and you have full access to it. Not the champions, but any of the other topics, which you'll see in a sec. I'm going to get into the organizational level stuff in a sec and the system level. So champions, like I said, there's thousands, and they range in sectors, and they range in specific topic areas. So for instance, I just heard that this week we have 400 people logging in for the webinar, because there's 5 series of webinars for the addiction and mental health champions. So 400 nurses and or other colleagues, and they're doing it likely at the end of their shifts. You know, we often do it at the end of day, so you can have the overlap in shifts and everything like that. Long-term care we have, and it was hard to see in that graphic I showed you, but in every single LHIN, so if you think of the 5 zones in Alberta, and maybe even break it down a bit more to sub-regionally, we have a nurse that has literally been either a DOC, a researcher, or a master's prepared, who helps with change and implementation and working with the healthcare aides and all the different types of nurses in all the nursing homes in their region. So they go to the region, they're assigned their region almost like you'd be assigned a group of patients in a clinic. The order sets. So what happened with this is that we realized that nurses don't have the time to read these lengthy things, right? I'll start to hand out a couple of them here, but so we actually took the core recommendations and we turned them into action items so that they're in nursing order sets, and then we coded them to ICMP because we felt it was important that as ICMP had established kind of the activities of nursing, that we should actually standardize to that nursing language. So I don't think I have to say too much more for a sophisticated nursing audience, but the good thing is actually I was at ICN this year, and so was Diane. We saw each other, but we went to an ICMP meeting because countries around the globe are trying to see if we can actually categorize. So if you look here, what you'll see is anything that's specific to, that overlaps with ICMP, it has a code to it so that you can start to actually have codification if you're actually evaluating the impact of these implementation efforts. This is actually the order sets that have been developed thus far, just as an example, and about 40% of the recommendations are mapped to ICMP. This is an example. This just is actually out. With the order sets, we actually got another funded project with Canada Health InfoWay to implement the order sets using these 4 different e-solutions, Meditech, Epic, Procura, and Point Click Care, into the e-health records to actually codify nursing care and see the impact and value. So just as an example, the benefits, you've got more practice use, expertise, early detection, prevention management, decreased healing time, and this was for wound care, decreased risk complications, and then for patients, improved quality of life, early prevention, and staff awareness. This was in an 8-month evaluation that just happened this year, just by actually standardized nursing care and having this tool for the nurses around wound care, because sometimes we become so task-oriented, we don't give nurses the amount of time that they need to do the knowledge uptake. So this enabled a focused effort, and in all these different practice settings, they did have a funded nurse peer leader. I already showed the BPG app, and it's free, and it's on Apple and Android devices. And they kind of look like this. And we actually, as we're moving our e-platform, it's going to even be a little bit more sophisticated and easier to use. The RNAO communities, so again, they look like this. You go in and you start a discussion, and we actually work with Australia, and they wanted to talk to the pediatric centers that are BP SOS, which I'll get into in a second. We just said go into the RNAO community and start a community, and then about 7 different organizations linked in, and these are all nursing leaders. what's my timing? Am I doing okay here, do you think? Are there any questions? Because I feel like I'm just ramming you with information. Are you okay? Okay.
We have maybe folks booked till 1:30.
Right. Yeah. Okay, we're good. We're at a good pace then. So we do have actually formal institutes, and there's the Clinical BPG Institute. And actually, we just had some folks from BC come to the one in June. And this literally, again, is how do nurses lead quality improvement in their organizations? And we have guest speakers, and it's not the association per se as much. It's those individuals that actually are leads in their in their organizations or sectors related to BPG implementation, and we focus on different topics. And I'm going to keep going. I told you all about the workshops. We have one day. So for instance, we have workshops that are just focused, say, on opioid use reduction or something like that, and then the nurses come on board. Some of them are webinar-based, some are internal. And what we do in Ontario is in live, is we actually, we kind of book them all over the province, and then we actually always get feedback from our member associations, because then what happens is you know how each region has its own subgroup of nursing leaders. They'll actually demand, so for instance, Ottawa was really mad at us because we put it in July. Who wants to go to a workshop in July? So we promised them this year we'd make it, a little bit like September, October, whatever. So we actually get feedback too around where they want to have them, and we tend to try and book them outside of the GTA because the GTA is so expensive, which is good. It's probably about triple the cost to rent a facility. So we tend to go out into the rural, remote, and or well into the suburban parts of the different cities. So just as an example, and this is one fiscal year, we engaged over 7,500 individuals. And when you think about this, the bulk of this, other than the institutes, which is 342, is free. So when you think about, just the uptake and knowledge development for the nursing profession, so it's really important that we continue to support that. And we've had government, and we've had, we in Ontario seem to change our government every 4 to 8 years. They keep funding the program, and so we'll hopefully this June they'll be doing the same. So I think that was the okay, so the best practice spotlight organizations. How many of you heard of that construct or concept or program? Okay, great. So what is it? So the guidelines were kind of up and running in the world of nursing in 2002, and actually Karen and I were just having a conversation about that uptake, that implementation science. You get it into the organization, but then it doesn't take hold, like any type of quality improvement initiative. So this construct was developed, best practice, as in BPG, spotlight organizations, so organizations that wanted to focus on quality improvement. And it was really to focus on the uptake of evidence and best practice guidelines, because it's actually gone beyond just the BPGs. It's tons of different evidence strategies. And we have now kind of affiliated with us are 4 types. We've got service BPSOs, which are predominant provider type organizations. We've got academic BPSOs, and then we have 2 types. We have directs, where they actually work directly with RNAO. And every single BPSO has an RNAO coach and or a coach of another BPSO, because then coaches become expert coaches and they coach others, and or a host. And I'll tell you what that means in a sec. But a host is, we have a direct relationship with the host, but they're the ones spreading the knowledge within their jurisdictions. So for example, Spain, the government of Spain, where nursing care was struggling about 7 years ago, the government itself hired 3 nurses, 3 nursing leaders, to become the hosts. And they got trained and came over to Canada and understood what a BPSO was and implemented in a few sites in Barcelona. And here we are 8 years later, and there's 80 BPSO sites across the nation. And it's completely run by them, and the only thing they have to stay true to is they translate all of these into Spanish. So they're all translated into Spanish, the ones that bring relevance to them, predominantly the clinical ones, is they have to be free to everyone. So they're on our website. So all the multi-languages are on our website. And they have to follow kind of the rigor of the program. So they now implement our strategic approach with their BPSOs. They're not our BPSOs, they're theirs. Does that make sense? So, before I do that, so how many BPSOs do you think there are in Canada first? Throw out a number. Take any number. 10? Okay, go higher. 100, go higher. It's actually, and then how about globally? What do you think? Globally is newer. It's only probably their last 8 years, starting with Spain. Okay. So there's actually over 500 healthcare academic organizations that are BPSOs, and then we work with them in these different conglomerates. So in Canada, it's just over 350, and then we have all these other countries. So if you can't see this, Chile, we already have a BPSO direct, but the government has just actually signed a contract to enable, so the Chilean nursing leaders, these are the university folks, these are the, the VP of the Regional Health Authority, that's a nurse, are now taking over and becoming the host like Spain is for their organizations. Peru has signed, and I think actually Doris, the CEO, is going down this month actually. Colombia is a direct. Jamaica, it's the University of the West Indies and the Hospital of the West Indies, and they just literally flew up to Toronto and visited us in March. Canada, we have them right now, Nova Scotia, Quebec, and Ontario, and then we are speaking with other jurisdictions, and we know they're being used. And what I'm trying to say to everybody is, like, first of all, I don't have the capacity. What we want to do is actually build the nursing leadership and implementation science programs within the jurisdictions and keep this global network going, because we are transforming nursing practice around the globe with nursing leaders in each jurisdiction. Spain, I mentioned. Portugal just got launched this year. Italy is a blend of the university. So it's actually the college that's working with the University in Milan, and then several healthcare organizations in Milan. So actually Diane met them because she saw them at ICN, and we introduced them to each other. And so literally it is the College of Nurses wants the university and the healthcare settings to get on the same page around nursing practice, and now they're working directly with us. So I have a call actually tomorrow with the college. Belgium, it's actually the University of Antwerp, and they've just become a BPSO, and now they're actually working with 5 healthcare organizations in Antwerp. So literally for me what it is I'll go to Belgium, but what I need is someone that actually speaks Dutch or French to go. And with Latvia, I'm literally getting on a plane next week to go to Latvia, and we're calling around the entire province of Ontario who's a nurse in a BPSO that speaks Latvian, right? So, because I'm not going to be speaking Latvian. And what's exciting about this is that so it's the World Congress next week, so it's all the Balkan nations and Russia are coming, because the Balkan nations are moving towards baccalaureate prepared nurses. And as they move towards that, they actually want to have evidence-based practice. Ukraine has been, as we all know, decimated, and I'm not sure if I have any Ukrainian colleagues in the room and or Russian, so not being political here, but there has been a lot of decimation of the profession. So the World Health Organization has asked us to go in, and this is all free for the record. We do not charge a cent. There's not a cent, because we actually, within our agreement with the Ministry of Health, cannot actually make any money. We're a not-for-profit organization. The only expenses are our travel expenses and accommodations. And then finally, China is kind of scaring us now. It's because it's sort of taken off now, and we're up to about 7. And so we're the first generation are kind of BPSO leads, and they're champions. So we're kind of wanting to make them a consortium so that they can do it. So we are going to China probably for another year or 2, and then we're hoping they'll just be a host to us. And Australia is actually further ahead than us, because Australians are a little more bold than us. What they did is they actually took the BPGs, implemented it. It was actually the regulatory body that did it, with multiple sites in the province of Adelaide. But then what they've been doing, and we've actually copied it, and I'm happy to send Diane the link, is they've been doing the value for money and return on investment analysis based on implementing. And it's quite significant by getting nurses to standardize practice, have time to think, have time to implement these evidence-based strategies, evaluate, demonstrate impact and value, and reinvest the money. So it's actually been wild to see the cost savings, and they're doing it over, whether it be falls, wound care, pain control, whatever it might be, recidivism rates with transitions in care, whatever ones they're implementing. So what does the agreement look like? Because it sounds like this, I was saying, you know, I'm always now afraid when I come back to Alberta, having been on the other side where I was in meetings now representing Alberta, and I'd see these kind of arrogant Ontarians thinking they were the center of the universe, and I'd kind of sit and listen to them, and finally I'd go, can you guys stop, right? Because I am actually kind of an ashamed Ontarian at the moment. But what I want to say to you is that really for us, what this is a true just spread and scaling up for the profession strategy to get the profession to actually optimize a ministry-funded resource and use it in whatever way it makes sense within their specific jurisdictions. So how it works to become a BPSO, you engage in a 3-year partnership. It's called pre-designation. And you literally implement the change management framework, you train some champions, and I'll get into it in more detail. You participate in monthly or bi-monthly meetings with myself or one of my colleagues, or it could be another academic BPSO that's fully designated. You have knowledge exchange opportunities as you'd like to go with, and then you work with BPSOs. And the really amazing thing that's come out of this is that we don't have the capacity to keep going, so we're actually training like champion auditors and trainers, and then obviously we have a research consortium that I'll talk about in a sec. So for instance, there's a VP in a suburban hospital in Toronto that is Italian speaking. When we got Milan, we sent her because she was already the executive sponsor and change champion, and we don't have the capacity. So she's the one that goes to Milan. It's like, really? You know, can I go to that site? No, I get to go to Latvia next week. So, which I'm kind of terrified because I fly from Latvia to Russia or to China, and I'm like, that'll be a fun 24 hours. But so in terms of the deliverables within the pre-designation stage is that you, as an academic institution, because each one of them is different, the practice settings have to implement 5, the academic institutions have to implement 3. So you have this pre-designation partnership. You implement a minimum of 3 BPGs. 2 have to be within a course. 1 has to be curriculum-based. So for instance, patient and family-centered care would be within the undergraduate curriculum. And it could be within a year. It could be over the years, because that's something you constantly visit, as an example. And then the other 2 might be specific to a course, like some type of clinical management course, or even a placement, you know, a final placement course in a particular specialty area. You have to have 2 reports a year. One's like mid-year and then one's at the end of the year. The 15% nursing staff or faculty, and it's usually, that's an error there, but faculty would be that 15% of you are actually trained in the Champions program, that you become part of the Best Champions network. You engage in the regular knowledge exchange, and I'll get into that in more detail. And that is stuff like the institutes, or the e-learns, or the webinar series and stuff, because you actually have to have attended a certain number, and it's usually 1 every year. Obviously participate in the indicator development. So for academics, we don't have indicators for academia. It's to actually help work with the International Research Consortium to develop some indicators, and then to help us with the current indicators, which I'll show you some of the results, and I know some of you looked at your evidence summaries. Have 1 manuscript or publication during that 3-year partnership. And we're not talking about what level of journal, it's just that you actually publish about your experience and or impact, and then develop a web page on your organization that's related to the BPSO program. So the last thing I'll just highlight in terms of implementation is the system. And this is where, when you think from an academic research change management perspective, as we got really proficient at this, and you had nursing leaders in the province, because it wasn't us, we're just the professional association, but you had nursing leaders in the province talking about this focused strategy on change implementation. We started getting funding for specific projects. So I already mentioned the long-term care best practice project. We also we actually have a program where we have teach trained coaches that implement tobacco reduction, and they use the BPG for the smoking cessation. And then we have mental health and addiction, because several of our BPGs are focused on that population. And so, for instance, and I'll send that link to you. I don't know if I did. In this initiative, we recently developed the Youth Mental Health and Addictions Toolkit. And it was a participatory approach where we actually worked with youth around what they think should be in the high school curriculum related to mental health and addictions. And so, again, government knows that kind of, when you think of many teachers and they do their whatever undergrad and then they do their BEds, they don't necessarily get a robust education and training in addictions and mental health. And so it was a collaborative with 3 school boards, with the youth, and then nursing led. And we created this incredible, and I can send you the link because it's available and free, kind of e-technology program for youth to go through as a curriculum related to mental health and addictions. And now it's had such great effect in the 3 school boards, more and more implementing it. And so when you think about from a nursing leadership perspective, that's kind of changing the conversation about nurses driving actual strategies related to different subpopulations at a population health level, and that we're kind of the leaders. And so as an example, the Ministry of Ed in Ontario just funded for this entire e-platform to be translated into Francophone for the French school boards. And so we're literally just finishing that up. I'm not going to, so are you guys shocked to hear some of this stuff that, no? Isn't this what nursing should be doing? 50% of us, like population health, clinical, we work in, we are the foundation of the health system and major system transformers. We also do so we have several MOUs. So we have an MOU with CPSI, we have one with Canada Health Infoway, and they're related to topics too. And I mentioned the peer leader one already. The eHealth BPG just came out. That was funded by Canada Health Infoway. And then CPSI worked on us with the person and family centered care. So evaluation, you're all waiting to hear the researchers in the room. So when I got there, I was worried that even listening to, because they were so focused on their data system, and I was kind of going, okay, wait a minute. A lot of what we do is qualitative, and most of the evidence we'd gotten to date was BPSO level, so more case study level, even though some of the qualitative stuff was quantified, and or they were using secondary data repositories or libraries, so CHI data and or RAI data to demonstrate the impact and value of their efforts. But I also knew that there was this rich, robust qualitative story, not only because I'd implemented the BPGs, but because every time I went into a BPSO, that's what they talked about, and I'll show you a little bit about that. So we have our Enquire database that I'll show you some of the outputs from that. But I'm going to start here. So we developed a data quality framework, and it's a final publication manuscript. And it really is a framework. I'm not going to go into these details around how we ensure that the data that we take from the BPSOs is cleaned and high quality, so that it can really demonstrate the true impact and value. And it's really the BPSO's data, but we're actually helping them. And it's an automated generated thing. So when they submit their data related to BPG implementation, they get it back right away, so they can actually see the impact of their efforts. We're using the Donna-BDM model, so structure, process, and outcomes. We have multiple data inputs, the data system, our qualitative reports, and then we're looking at secondary data repositories. And we're doing, right now we're really only advanced on these 4, I'd say. We're just starting the implementation science research, but we do the quantitative, the qualitative, looking at secondary data sets and impact, implementation science, and we're just starting to do a prototype on comparative research. Again, when I'm saying we are, this is with the research consortium. It's not us on our own. I have that tiny team, and I remember the box on the right-hand side. We are the thinkers, and sometimes we'll be the ones that actually manage the data system, or we have a research advisory committee, so we'll talk about this, but really the research opportunities are for the profession. We've started based on what Australia did to build in the economic impact analysis, and really our goal is to demonstrate the value of nurse-led, change management and quality improvement strategies within BPSOs that influence both practice and policy. So how many of you had heard about MBPRC before? Okay, a couple of you. So way back, I think it's now almost 15 years ago, the University of Ottawa was like, hey, this is kind of cool what you guys are doing, and how about we do a collaborative? And so in the requirements for the Ontario BPSOs, they must become members. So when you see these numbers, some of them the organizations join, and some of them the individual BPSO champions join, and the number's always changing. I just got the number, because some drop out once they've got their designation, so it kind of ebbs and flows. And so we have an annual, I think we're going to move to biannual report. Now this is any type of, so it's not only BPG related, it's any type of quality improvement, any type of case study that involves nurse-led interventions. Hi. No, no, it's just the federal. Do you know what the name was? Oh, okay, so maybe there was federal funding at the beginning, I'm not sure. But now it's really, it's provincial funding that's supporting the site. So the University of Ottawa actually has a research program with some paid staff. They have 3 paid staff that actually do this, lead the program. And we are just kind of, in a way, I'd have to say we're having been now in the role for almost a year, but we're kind of their touch point to what's available sector-wise in terms of research opportunities, and also giving them updates on some of the new implementation science strategies. And I'll show you a little bit more about them. But so this was just last year. Anything that was nurse-led research studies that was quality improvement was published in this as one place to show the impact of nursing leadership and research, or leadership in implementation science and then research. I said to Diane in a conversation, and Diane, kill me if I said, well, like if I was in Alberta still, I'd be saying, why don't we have a Western MBPRC, right? Western Canada MBPRC? Because, you know, that's one of the things is, you know, if the center seems to do these things, but we need to spread and make it jurisdictional relevant and start to build that knowledge. And one of the things I'd say, being the chief nurse here in the province, is it didn't matter how much evidence I slapped in front of my ADM colleagues or the DM about certain problems that the system was facing, unless it was Alberta evidence. They just would disregard, oh, Val, that happened somewhere else. I would get that, and I'd be like, oh, right, like, but there are 3 Alberta articles, right? But you know, we really need, and you know, we're too small to do it every jurisdiction. Like you could have a west and an east. We're just too small. 4 million people here, 4 million people next door, you know, a million. But we need to actually put together the evidence in a way. And that's, you know, I think through the leadership of the academic institutions with, you know, multiple quality improvements. So if you even looked at this report, the BPG implementation of these 235 research studies might be 20%. It's any type of nursing research, but even 20% is good to get going in terms of implementation. And the implementation science strategies are just starting to be reported as well. So for those of the qualitative researchers in the room, we have this amazing thing called My BPSO. It's a web-based report where they go in and they talk about capacity development, their dissemination strategy. This is for implementation science. Their accountability structure, the implementation activities at the unit level, at the course level, and they actually report what they're doing that's actually changing practice or changing or improving knowledge or advancing knowledge. At the end, more their sustainability and their own evaluation, and then overall reflections. So we codify this so we can quantify it, and it's really some compelling things are coming out of it. And I'm just going to give you a couple of examples of the My BPSO reports. Here we implemented in one nursing home the oral care BPG. So this is one little nursing home, and in Sioux Lookout. And this gentleman, before the oral care BPG was systematically introduced to that nursing home, was no longer eating. He was on NG feeds, and he was no longer speaking. And once the nurses actually standardized their care and implemented the oral care strategies, he went from NG feeds, most people think for the rest of his life, to eating again and speaking again. So from a nursing perspective, and I always choke up when I talk about this, like, you know, the fact that we don't have the time to do oral care based on evidence is shocking to me. And I know it might be our PSW or healthcare aid colleagues, and they don't know what that is, and we need to have the time and space to demonstrate that to them. But here you have a gentleman that can eat on his own again and speak to his family and friends and his co-residents. Trillium is the biggest community hospital in the province of Ontario. They implemented, related to the delirium, dementia, and depression, was the 10 at 10. So it started on one unit and it spread to the entire organization. Now it's not always 10, but 10 minutes of exercise at 10 a.m. facilitated by anybody on the interprofessional team. And they've not only had improvements in their delirium and dementia, they've actually had improvements in falls and pressure injuries. And they've done Trillium, the VP of nursing actually just recently presented the cost savings on this simple strategy that came out of the recommendations around mobility and keeping people functioning, things we know we need to do. Another one was, in the same one, is most patients were sitting in their beds for meals. That's something insane, like 90% would eat their meals in beds. They switched it to 67% eating in their chairs, which is what they did their entire adult lives, and that just had a dramatic impact on their cognitive functioning, that they did what they always did their entire lives. This is hard to see, but this is actually for the patient and family-centered care. This is a picture. So when they implemented the patient and family-centered care, BPG, throughout the organization at Blue Water Health, this is actually a composite picture of every single staff member, and it's like micro tiny for the hospital. And they made it in a way that and they've created this person, Emily, that every decision the organization makes, they have to think about the impact on Emily. And Emily actually has a room at the boardroom table. And her picture is everywhere throughout the organization. So by getting the corporate involvement, and you think about some of the things, and some of you are probably working in practice settings still, like the kind of juxtaposition you find yourself in, the paradox. Yes, family-centered care, or child family-centered care, but we're not able to implement that. But when you get that buy-in and you use those change management strategies, you have huge impacts. The final one is more from a staff engagement perspective and professional development, but Public Health and Grey Bruce Health Unit, they now have all of these programs in place, and they have actually established now a regional nursing network. They're not waiting for permission to do that. They realize that they need to actually continue to advance the profession based on now having the tools to be the champions for their regions. I was looking at the chapter, because there's actually a chapter. 3 of the earliest academic BPSOs are finally writing their stories, because the academic came after the service. And the minute it is go live, I will send it to you guys, because I'll send Diane a copy. The book, STTI is publishing our book. It's a 17-chapter book about this whole journey and the impact and value, and it should be out in February. And from an academic perspective, what's happening now is the academic consortium, and I'm going to go back to the world map just for you guys to have a sense, because, So the academics are here, Spain, Italy, Belgium, Australia. Latvia is actually the academic's going to be the lead, and then obviously St. Avex and in U of O, and then we're doing our first funded academic BPSOs here in Ontario. So we have a few applicants that will get funding. In Ontario, each BPSO gets $35,000 a year to sort of support probably half of a resource to help with the implementation. So I'm getting to the end so we can kind of have a conversation. But so NQuire, this is the nursing quality indicators for reporting and evaluation. And I could go on about this forever, especially with the research folks. And we just had our International Advisory Research meeting. But really what we did is based on the BPG recommendations where we didn't see existing indicators. So these are new, novel, nurse-sensitive indicators. We actually created new indicators, what we call process indicators, because it was around the means. And then we also looked at outcome indicators. Some of them would align with whether it be any of the other data repositories. Some of them are new, or some of them are evolving with other data repositories. So for instance, the incidence rate of falls is not new. So we would use that, but we would put it into our system because that would enable us to actually look at changes in practice and the impact on outcomes. So we wanted to develop this robust data system. It only came out in 2012. This also received government funding. So this team is funded by the province of Ontario. And we have, of the BPSOs that you saw on the map, about 90% of them are participating, some because they're new and some because they're so old, like the 2002s are saying, why would we give you our data? Just use the secondary data, because they're now masters at quality improvement. So anyways, it's a system of quality indicators. And what we do is we have, a web-based system where the BPSO lead or their decision support goes in and updates the data. And really, we're not asking a huge burden. It's per BPG, a minimum of 3 data elements. I would say 1 to 2 process or outcome, and then they do structure ones, like the staff mix ratio, because we kind of are being a little bit I'd have to say strategic, around understanding too how the nurse staff mix ratio is impacting on the quality too, because we want to have more characteristics of the BPSO. So we do collect that, and absenteeism, like we collect the standard nurse workforce structural measures as well. And I should have just said that. So, and these we only get on a yearly basis. So at the end of the year, these we get either quarterly or monthly, and these we usually get quarterly because it's the way they flow from the organization as well. And every single indicator has a data dictionary, like they should. And these are examples of BPGs that have indicators. Obviously, some of the top problems in nursing care. And the way they, so there's an agreement for being a BPSO. There's also an agreement around the evaluation. For academic institutions, we don't have indicators yet. We're going to work together to think about whether or not we even, we're thinking, do we create academic indicators, or do we just continue to advance demonstrating the impact and value of nursing? I'd say that the international folks think that we should be, even when we think of comparing jurisdictions or universities and whether it be, and I don't want to say the word NCLEX, but pretend it was CRNE still, that if we looked at sort of, which schools embed different types of interventions into the curriculums, and does it impact? And that's where the other jurisdictions are going. If we embed them, do our students do better, regardless of what the final exam is, right? And so Belgium actually has he just had something published in an international or European conference around the indicators they were looking at. So for example, it was the students had a BPG implementation project within the 4 years that then they published. So in his particular program, there were 5 publications from students, which was, is that an indicator for success when they go out into their careers? We don't know that yet, but those are the type of things, or if it's integrated along the curriculum versus just in a course. So these are the type of things that we're trying to see from an implementation science perspective, but it's early days. So the way it works for the practice settings is they literally log into nQuire, they put in their data, and then they get the reports. And we have 3 types of reports: single indicator reports, overlay, so this is the means to the end. You could look at process to outcome or compare outcomes or compare different types of BPGs, so you could see a correlation if you implement several. And then we're looking at some of the statistical analysis. We just literally hired a statistician with a PhD in January. And so our level of sophistication around our data analytics has really improved. So here's examples, and I'll go through these quickly. 2013, you implement the pressure injuries BPG. And not only do you have a significant drop, you sustain. And this is quarterly reporting. Another site, hospital incidence rate, and you sustain. This is home care, slower drops. And obviously home care is a little less predictable based on the types of surfaces that people are sleeping on, but still sustaining in a drop. This is falls, still sustaining. And so we're doing costs. And so that's what you see in the BPG evidence boosters that you have in your handout, is there a little more detail about these and what the actual interventions were. Now we go to secondary data. This is actually RAI data. One nursing home implemented 12 BPGs, and they saw drops in every single indicator. Now, what is really horrific about Ontario, not so much Alberta, is that we actually have this perverse funding system that if your patients are lower acuity complexity, you lose the money. So how this whole finding has helped us, and literally what happened is I was reading as I was doing my orientation, and I came across a newsletter, and they were talking about these results, but it was all in words. And I said, can you guys verify this? Is this really what happened with the RAI indicators? Yes, it did. So we actually went in, and all we did was quantify. Like, this table literally took 10 minutes to produce. And then we sent it to the ADM that funds the long-term care facilities and said, hello, because this home actually had funding removed because they improved their quality of nursing care and patient care, or resident care, I guess. And so now we have a whole policy agenda. This is literally just in 6 months by nurses having evidence to tell government, change your funding model. And so, we underestimate that the policymakers, now that I've been in that world, are actually making necessarily the evidence-formed decisions, because they wouldn't know how to get to this evidence. They would never see it this way, that this particular home got better and you actually did this negated funding methodology with them. This is a comparison of a long-term care home that implemented the least restraint. They went down to 0, and this is them comparing to the regional authority, to Ontario, to the rest of Canada. So when you put those in front of decision makers, they kind of go, wow, we want to see more. And you have these bits, so then this was sort of my world. You know, all of you have ever seen any of my presentations. I'm all about infographics. This one's pretty busy because it's a bit more researchy. It was for ICN. But we've started to produce these, and we have sent them to every single CEO in Ontario, the LIN CEOs, the ADMs, the ministers, to let them know that when you minimally fund evidence, you know, being integrated into nursing practice in a systematic way, these are the impacts you get. I wanted to kind of tell you a little bit about the advisory council, because when I think of a university, this is where I think they should sit. Some of you probably know Judith. She just stepped down as president of ICN, and Doris is the CEO. And if you've never seen her, she's the most colorful person you could imagine, Diane. Spanish flair. Yeah. And she really is the brainchild of thinking nursing can do whatever, like exceed, you know, like she's kind of, and so she pushes, she's, you know, I was called a gentle disruptor here in Alberta. She's not so gentle. So I went somewhere where I'm more or less gentle, because the gentle wasn't working for me. So, so I just wanted you to get a sense of the quality of the people. You have Judith chairing. You've got Denise and ADM. You've got Nick from OECD. You've got Maggie from WHO. John Lavis, a lot of you know, right? You've got Kai Hai there. You've got the Canadian, like ASIN, the Canadian nurse executives there. You've got a Spanish representative. You've got Patricia Patrician, who's done tons of nurse workforce and impact and value in the US. This is a patient who happened to be a nurse that survived cancer. You have another, this is an implementation science expert, Dr. Ann Sales. This is Canada Health InfoWay. Dr. Josh Tepper is the equivalent of HQCA CEO. You've got Accreditation Canada, who happens to be a nurse, and you have the Peter is the University of Antwerp. These are the people talking about how do we take those results and spread it and demonstrate our impact value and value for investment and our return on investment. Because if we actually have the right nursing care with the right supports and evidence, what can we achieve? So we just actually spent 2.5 days together last week, and they were blown away, because I'm showing you a snippet of the results. They couldn't believe in such a short period of time now that the data system's being built with the qualitative components where we're going, and then looking at the secondary data repositories. In terms of those of you in the room that are into implementation science research, so we've been focused more on BPG implementation and evaluation. We're now moving into the world of implementation science research, and we've established a research collaboratory. And I just wanted to show you the membership of that. It's a little local, but still has some international flair and a bit of national. But we've got Doris and Ann again. We've got Melanie, who's Research Institute at Sick Kids. Wendy, U of O, myself, Bahar, who happens to be a long-term care director, who is just, their home has just done phenomenal work. Heather is one of my staff that provides the secretariat support. Spanish. This is the research associate director, Janet Squires, that is at U of O, and then Bayshore, another clinical. And these are the things we think if we actually built the research collaboratory a little bit more across the nation and demonstrate the impact of, you know, nurses leading quality improvement. Last one, but this is now provincial, and I thought it would be important for you to see. So by us demonstrating impact and value, the other professions are kind of like, hey, what are you guys doing? And so the minister, Deputy Minister, Dr. Bob Bell, the executive sponsor, said, can you bring together all of the kind of implementation science folks and optimizing evidence folks and start to have a strategic conversation so that we make sure that we are, it's not just HQCA, that we're actually grabbing on into, and SCN, but we're grabbing onto every asset and making sure anybody that's leading an implementation science initiative program are having a conversation so there's no duplication. So, you know, when I think of this, I think some of the stuff that you also need to know, I mentioned the Spanish. It's actually translated into 8 different languages. It's free and accessible. We're impacting nations around the globe. We continue to span. We've got now the evaluation data system and the order set. And we've been working collaboratively with ICN around the ICMP things. the thing I've kind of hinted at throughout the presentation, the other thing this has done, because you always think of like policy being separate than practice, but here what was happened, just as an example, is there was in the news all of these stories about crib death. We actually, the minister literally picks up a phone and says, can you guys do a guideline on, safe sleeping for infants based on these stories? So we create this, and once this was implemented in sites, we actually had lower SIDS, right? So like these are these things where policy asked for something, practice implemented it, and actually impacted on outcomes. Here's another one. This was national, and actually the previous associate DM of Alberta, Susan Williams, anybody ever meet Susan Williams? She was the co-sponsor with the DM in Ontario. And the diabetic, we have one of the worst amputation rates in the OECD countries. We have terrible amputation rates. And amputations cost about $70,000 a foot, and we're not talking about any of the quality of life costs. Just to cut someone's leg or foot off is 70 grand. And we have a high amputation rate because likely it's a pretty lucrative billing system. And I'm not saying, it's just, there's no other option. So we went and we were like, oh my goodness, we need to actually change this, because why do we have the worst amputation rates? So RNAO, the policy started, took amputees to Queen's Park, so the same as your legislature, and said, we should not have lost our foot. If someone had been managing my foot care, we should have not lost our foot. So we developed an evidence base based on systematic review. And then what led to, and in there, we had actually said we need to fund not only the total contact casts, but we also need to fund the offloading devices, the removable ones, because they're anywhere from $150 to about $1,300. And by actually having that an evidence-based guideline, the government was only going to fund the total contact casts, but because we demonstrated the evidence, said no, if you can do the removable casts, then you actually have the individuals being able to take their cast off and like elevate their foot and blah, blah, blah. And there's a drop. And so the policy changes, they're funding all three types now, versus the evidence from like the empirical RCT evidence was only the total contacts, not the offloading. It was more the qualitative case study-based research that was showing that got built into this BPG. These things give me the heebie-jeebies, because it's actually wild. Like when you think about it, that's a 70s word. Anybody ever use heebie-jeebies, or no? Okay, that's an Ontario word, oh my God. Sorry. And then the last one here is like we've always had these, methadone and substance use. But when the approval for the supervised injection sites came on, literally the mayor of Toronto said, hey, Doris, can your BPG team create a SIS? That's nursing working with policy in ways that we should be doing across this nation. So in finishing, for you guys to contemplate, especially now that I'm your colleague, I'm just going to give you a sense of how it would work, just for you to think about, because I know our plates are all full and we feel overburdened, but if you sign the BPSO agreement, from the 3 years, you develop some type of internal steering committee, right? And that's you to decide your structure. There would be some type of orientation within the coming months or in the winter, and you would complete training of champions. So that's 6% of your staff. So let's just talk about, and we'll do simple math, right? But if we're 6%, and you had 30 staff, then that's actually only 2 people, right? It's not a huge number of staff, but you need champions that believe in implementation of these things. And then in the year 1, you start to implement 2 BPGs. Usually you do one curriculum-based over like into year 2, because it takes a while to think about how to embed, but a course-based, because you're probably already doing it, some of you, where you're using it, and then you would get the ideas from the other academic BPSOs in terms of how to evaluate. You'd have monthly or bi-monthly. I think like we do monthly with a non-English speaking, just to make sure, but for the English speaking, like the St. FX, we only probably talk to them every 6 weeks. It depends on when they want to. And then there's a mid-year report year-end. And so then in year 2, you have to implement the 3rd BPG, which tends to be more the curriculum-based. You continue to do training of champs, so you need another 2 people if you had a staff of 30 in undergrad, for example. You develop sustainability plans, because you're going to become a BPSO designate, continue with the meetings and the same reports. And then by the end of like the start of year 3, you want to think about how are we going to kind of actualize ourselves as a BPSO, and that's when a lot of the BPSOs, especially the academics, start to think about, am I going to work collaboratively with AHS or just with a particular implementation site here? You know, Karen was lovely enough to invite me to go to the CHC here, CUPS, right? You know, you could pick a site that was interested in a strategy or whatever. And so you finish off your training, so that's 3 people, so there'd be 1 more person, so that you can actually say 15% of your staff are trained as change champions using the knowledge to action framework. And you establish a plan to sustain 50%, and then your meetings end, and you get the BPSO designation. In Ontario, so for instance, last year, the BPSO designates come to our AGM, and it's not, because there's, I think, and this is more critical mass humans, but the AGM usually has about 600 to 800 people at them, and they're at a downtown hotel. But the Premier comes, the Deputy Ministers come, several ADMs, opposition come, and the BPSOs actually stand up and get their big, huge plaques that go on their hospital walls or their long-term care walls or their university halls with, I'm now a BPSO. And it is, and the other nations, it's similar. Like, it is a huge event that nursing is being elevated in ways it hasn't been. Like, we know we're using evidence. You know, and Diane and I talked about this, Karen and I have talked about this, like, we're integrating evidence. There's hands down, but it's not actually changing. And if I was to think about when I became a nurse I trained in the 80s into the early 90s, I actually think we're kind of going backwards a little bit in some of the jurisdictions around our power base and our influence on decision making and our true value and impact, and we're losing power. So when you have evidence like this, what you're seeing in the jurisdictions is, yes, we have our third world countries. These nurses are like all of a sudden gaining more power than they could possibly imagine in 5 years. Like, we're talking Colombia, it's been insanely transformational. But and something like Italy or Milan, Milan is very hierarchical, physician, male dominated. Even the CEO of the, you met him actually, Diane. He, like, every time you addressed him, it was like, I felt like I was talking to, like, I don't know, I don't want to say this out loud, I'm being taped, but like a mafia boss, right? Because everybody would like, because it was just like, it was like, did you speak to the Don? Yes, I did, right? And it was really like everybody deferred to this gentleman. But what's happened is now there's conversations with their physician counterparts or their interprofessional colleagues like never before. In China, nurses did not provide wound care. Literally. It was a physician function. And now nurses across the nation are providing wound care based on 5 implementation sites. So these are the impacts that we're having. And when I say it, and I always say this, I know I'm representing a professional association, but for us, it's not that anymore. It's a global movement, and we're transforming nursing practice in every single jurisdiction. And we are, regardless of if you become a BPSO, and I want to kind of leave it on that. Have a little bit of a Q&A if there's anything you wanted to ask me or hear further about. So thank you. I'll just put these out for those of you who've never seen a hard copy.
Well, there's sure to be questions or comments. We need you to use the mic for the videotaping, if you would. You're going to start us off?
Right. Start with a question. So Valerie, I'm curious. One of the ways that we have tried to embed practice change is to try and create something like embedded in something that doesn't change. So embed some of our intervention work into the CARNA continuing competencies.
Right.
So how could we, if we were a BPSO, how could we embed some of this into the CARNA continuing competencies? Or is there an opportunity to do that?
Right. So it's hard for me. So in every single BPG, we have a representative from the college, the union, and the RNAO. And so when we get a change in practice, especially when we're actually saying no longer do, there's usually then a conversation with the college around what that might mean or impact on the standards, because we do want to make sure that all the nursing bodies are involved. So I don't think it happens, just in time, but because it would have to be something pretty substantive. Because when you think about most of the nursing standards, they're pretty broad in what they say. So it would have to be if it was something substantive. And I know, when I think about the Alberta scores, say even on the clinical management side, on the NCLEX, and just pretend the NCLEX wasn't the issue, but if that was our approach, you could look at the clinical management BPGs and see if that could actually help with strengthening curriculum. That would be an opportunity.
Is there, Valerie, the presentation was very helpful to bring context. Is there a consideration that we could be population specific around this? So, focusing on, because you can't do it all.
No.
And so if the interest was around neonatal care or child care,
Right.
is there an opportunity to then focus within that?
So you're saying within a curriculum?
No, within the
BPGs?
yeah.
So if I go to the list of them, I will say that most of them, not all of them, you'll see there's an asthma one for children because Sick Kids had asked for that. Most of them are, I would say more than the clinical ones, most of them are adult focused. But more and more, especially with falls even, because everybody of every age falls, they ask for an all ages. So I'm just going to the clinical ones. So for instance, in public health, the things that they would implement is the childhood obesity, women abuse, obviously the safe sleeping. The asthma for control in children we're probably not renewing because there's better guidelines. We also make that decision, there's better guidelines, why would we renew? The substance use, whatever. So if I was to go to Toronto Public Health, what I know they actually they implemented was this one, this one, this one, and this one. And this would have been specific specialty units within the public health programs. And academically too, if you were, say, mental health and addictions, you might, like if you go to the clinical ones, you might pick a subset of them. This one really was only for older adults, 65 and over. And where's a recent one? Crisis is all ages, as an example. Crisis is somewhere else now. So did I answer your question? You have to decide in terms, because really the BPGs, you would look at the scope of the BPG, and if it was a specific subpopulation, then we're going to have a disclaimer saying the child literature wasn't evaluated.
So it has to be picking within what's available.
Picking within, so when you implement as a pre-designate, we like you to pick the clinical or the foundational ones because they're the healthy work environment one. So for instance, you might in your master's program use the nursing leadership one as an example. Hi.
Hi. I think my comment and question will probably quite in line with what the heroes were just saying. It's lovely to see that you have the PPSO from in other part of the world, and I don't see the Middle East that have a PPSO there. And given that we have the campus in the Middle East, I thought that would be really would be really applicable if you would bring this information and presentation to that point, right? Yeah, and and I could see that it might be for for UCQ, but also for nursing organization in the Middle East as well, because they don't have that kind of things at all in the Middle East. And a lot of their nursing scope of practice is very different. You mentioned that in China, the nurses doesn't do wound care, but now that they do. And similar in the Middle East as well. Nurses still do not do, it's not in their scope of practice to do the clinical breast examinations. That's for physicians. So, something like that will, a lot of things that I think would be, I know that you have translate this information into 8 different languages already. Is there one in Arabic?
No, because it's actually, we don't translate it. So once we get a BPSO agreement, we have a translation agreement, and we literally send them the Word documents of this. They translate
do
it,
it.
and then we reverse translate it. So we have someone here that's fluent in the language read it
Yes.
to make sure it stays true to the true intent of the evidence. And that usually takes 3 to 4 months per BPG, depending.
Oh,
But for
okay.
instance, China, because I'm going there next weekend, like not this weekend, the following, they literally translated one. I have no idea. They had a super team of translators in about, I'd say, a week. And so now it's coming back to us, and we'll have a Chinese Mandarin-speaking Canadian read
Yeah.
it, having like very in-depth knowledge of the English translation.
But China is very big. So in which province have you have the PBS already?
It's predominantly right now near Beijing, but
Okay.
we're like, so Japan friendly, Peking. I should know this. I was going to print off the names. I actually was going to do this and I forgot. It's predominantly all around Beijing because that's where the spread has started. But what we want is the consortium of them. I can send this to Diane, the actual names.
Yeah.
I do have it on a stick somewhere, but I don't think it's here. And so once there's 7 of them, we're just hoping that they'll spread.
Yeah. Hunan would probably be a really
Yeah.
good province for you to do it as well. Yeah, thanks.
Great. Thanks for asking that question, Tam. Tam was at UCQ for 3 years, 5 years, so she knows the situation there really well. And the reason we're videotaping this today is because they are so excited about being partners potentially with us in this initiative there. Deb is really keen. Deb is a KT implementation science guru in her own right, but also one of their faculty members just joining them this fall came from St. Francis Xavier on the East Coast, who have been immersed in this as well. So they have a Head Start kind of resource person there on the ground who could help with that. So we'll definitely be following up with the leadership team at UCQ to keep the conversation going as well.
Thanks, Diane.
Thank you for your presentation. It was very helpful. I just have a question. And the first, I think it was the BPG you shared, you showed a Indigenous health kind of component at the end. Have you included that in other BPGs, or what's your plan related to Indigenous health?
So that's a great question. And I didn't even share, this just literally got, I don't even know. We work a lot with First Nations Inuit Health Branch. I know they haven't changed their name. And so, for instance, right now, we signed with the Chiefs of Ontario a memorandum of understanding to help advance Indigenous nursing. So because the Chiefs are pretty excited, because RNAO is very different because it's only the association. It doesn't have the regulatory function, so it gets to advocate in ways that the joints don't. We actually work really closely with the national and the provincial Indigenous nursing groups. And so just recently, Health Canada has asked us to implement the BPGs and the implementation strategies for Indigenous nursing and or Indigenous care. And so we're actually kind of starting backwards. So we're going to go back and reverse engineer with them. So a lot of the funding is actually to look at what we have existing that they want to implement, and making sure we make sure that it's sensitive to Indigenous culture, language, et cetera. Because when you think about, and this is the thing, the binding, the scope has probably been the biggest issue. But, how could you have a substance use or tobacco reduction BPG without actually referring to Indigenous? Like, you look kind of naive and like a colonialist, and that's what they would tell us, which they do. So sometimes we do an add-on, but then that's tokenism, so it's disrespectful, versus what they want is a whole of education strategy, knowing and they respect that we have finite resources. Like the development team's only about 10 people. So it's a pretty lean, mean machine of nurse, and they're all nurses, and they either have PhDs or masters, and all they're doing is producing these things. They're on a 2 to 3 year cycle. Yeah.
Could you give an example of, I'm trying to visualize the implementation of a BPG led by an educational institution. Can you give an example of an implementation?
Yeah, so so what it would be, let me go to the list. So they might pick, I'll pick the leadership. So in the graduate program, if you go, maybe I'll pick one that I have, because I know I've read so many of them. Let's pick one. Oh, probably pressure injuries. Okay, let's do pressure injuries. So in one of your clinical management courses, what would happen is that, literally it might be in year 1 that it's a reading. And that you would, because you're maybe going into some type of clinical placement where there's wound care. And then year 2, it might be that you do as a student, and it might even be year 1, but often it's not, an assessment of best practices against current practice. And they would do an evaluation, and with their preceptor, they would actually sort of share with them their findings. And then maybe in year 3, if they were still interested in this topic area, they might actually do some type of project when they're in clinical placement. And by year 4, they might actually do a small publication with their like a prof. Like that's an example. And every topic's a little bit different. In the University of Antwerp, they've made it a requirement that they have to publish, and that could be a poster presentation, oral presentation, and or a manuscript before they graduate, related to one of the BPGs they've implemented in their curriculum. But this is where we're kind of co-designing together and new, because most of them, because they are so specific, especially the clinical ones, it really is related to clinical placement, versus the interprofessional ones or the leadership ones might be more of a professionalism course. And you might do an assessment of, like, so similar, where you might do an organizational assessment of, like, so does AHS have these leadership competencies in the leaders that you interface with as a student? And they would actually do an assessment, and then they'd write a paper for you. And that would be then their project. Now, again, they're using, don't forget, all of the systematic reviews, there's literally, like we usually, when we do our systematic review and we get the search back from the health science librarian, there's probably over 10,000 articles. And we've just recently purchased Distiller, which is a scanning kind of, what's the word? SEV. It goes down because literally these young nurses, I call them young because they are certainly scanning abstracts of 10,000. And so we're trying to actually eliminate ones and be a little bit more specific in what we're looking on. And now that we're using GRADE, the research questions are more specific, so we're getting smaller scans, like 2,000. And for them, because they're young, like I don't know how they do it, their eyes are young, they are actually on 700 scans a day. And they scan, they include, they exclude based on the criteria. And then once they get their 70, usually there's about 70 articles in the end. Plus they use existing guidelines because they use Agree-To to look at existing guidelines. So they've got the Agree-To review. They've got the experts that are on the panel that actually tell them if the article doesn't come through on the search, but that happens in less than, I'd say, 2 to 5%, depending on the topic. So sometimes there's hand selected, and then they have usually about 70 to 80 articles that they review. We also have students that come in, just as an example, and actually help with, so right now we have 2 master students that are in with the BPG team. And they're learning how to actually develop evidence-based guidelines. Yeah, hi.
I've got one over here. Linda Watson is another adjunct faculty member joining us today. Glad to.
So I sit over in AHS as an implementation science lead in oncology.
Right.
So my question is around, do you have foundational BPGs in development on things like telephone symptom management for nurses? That is a big, hot area in terms of the value add of nurses interacting with patients in virtual ways. But we don't have the evidence. We don't have that. So it's just a question.
So this is how topics would bubble up, because we have so we have 53. We're going to actually sunset some of them. They'll be retired. We only have the 10 or so folks that are ministry funded. So, we're on a production cycle of 5 to 8 a year. We're going to try and improve it. So let's say something like that came up, and it's kind of as we move towards e-solutions and the impact that has. So we just did an e-health BPG, but it was more at the system level, at the organizational level, than at the practice coalface level. So it could be that Canada Health Info Way says, you know what, because they're having such a great time with us with the MPLC project with the BPGs being embedded into the software, that hey, you know what we didn't get to is actually the virtual care, that whether it be technology enabled care and or e-solutions where we're communicating in new ways. What we've also talked about though, because we're really a true guideline shop, what's missing is kind of like we're more meso, a guideline's more meso, the micro, and in some ways depending on topic. So we have been talking about, because sometimes we do develop tools out of the BPGs, that if that was something that, say, bubbled out of the e-health, you know what we missed though is this, then we might do a smaller project that just worked on what would then be an associated resource, an evidence-based resource. It wouldn't be called a guideline. Does that make sense? Yeah.
No, just two comments. One, I worked on the abuse one out with Susan and Tasha, and it was an incredibly rigorous but extremely rewarding process.
Oh, great.
So I think I would commend you for the process you do use. The second point is we actually do use your guidelines in our undergraduate program
Right.
already, certainly within the first year and second years. So I think to go back to Graham's question, there's lots of ways we can continue to build on that
Yeah.
in our undergraduate program.
And so that's my point to all the, like, having been an academic is like, you're already using them. Why not get the designation and open to the global network? Like, that's what this is my Val sensible like the reality is it's not about RNAO when you become the BPSO, it's about this global network. And as researchers, it's the research consortium. If some of you are interested in doing like travel to Antwerp or something, or travel anywhere where there's an academic BPSO and you just want to even see, a lot of them will fund, like it's kind of, you know, Canada is is kind of considered right now this sort of, we're the Switzerland of nursing in a way. And so we're kind of going into every jurisdiction, from communist jurisdictions to third world countries to more advanced than us in many ways in sophistication around some of the ways that, you know, society works, where nursing actually has more power, right? And so I would say to you, like, to me, when I talked to Diane about it when she was at ICN, I just said, you guys could probably get your status in 2 years because you're already doing, but you have to formalize it. But you can't, like, it's a 3-year process, but by third year you're doing sustainability and it's a sign off. And then you're working with your colleagues in Qatar as an example or wherever, and or you're starting to do collaborative research around implementation science, right? Like whatever it is. And RNAO is kind of invisible. Once you're a BPSO, you communicate with us once a year and use all of our resources. Like we're not, you know, overseeing you. Like this is to help you continue to integrate evidence in a way that you can then interact around the globe.
So just a quick show of hands. Sorry, I might have had my back to the group when Valerie was asking earlier, but how many of you have used the guidelines in courses that you're doing and teaching? Yeah, lots of you. I'm not surprised to see that. They're great resources. I'm using the leadership one in the graduate level course that I'm teaching this fall as well. We're going to try to find ways to sustain this conversation, and so probably as a next step, we'll probably just do a email to everybody who is here today and ask for people who are interested to come forward, and collectively we need to figure out next steps and whether there are people who really want to become BPSO champions, or, you know, what it would take structurally for us as a faculty to take this on, and some of the questions that we might have collectively to figure out.
It might be helpful actually finding out what we do now first in our programs and then moving ahead as a base.
So the proposal, and I was saying to Diane, it's only a 10-page or so proposal, and it's web-based or Word, whatever you prefer. And that's actually something that's in the criteria. You would say, are you already using them? And then it would just, and so that'd be great, you are, so that you know what they are. And then it's just, then what happens? The next thing, so once you set up who's the BPSO lead, who your steering committee is, so say it was the undergraduate faculty and you had some type of curriculum steering committee, they'd be the steering committee. So you're not going to create new infrastructure, you're going to optimize and use, but you would have 1 to 2 BPSO leads. And then if, say, you had implementation BPGs in certain ways, so one might be that it's across first year or it's across the entire undergrad curriculum, so you'd pick different BPG leads for the 3 BPGs, and that could change. So there's your governance structure. And then the next thing that happens is myself and a colleague comes out, and it would likely be an academic colleague that has been a BPSO, would come out and actually do the training. That's opened up to everyone. Like, it's not just the 3 or 4 people, it's the entire faculty that want to come. But it would have to be during a reading week, or because it is a 3-day event where you just get a sort of download of the structure, and then off you go. Like, it really, and literally, it's hands off. Like, you know, I feel like we're kind of, Canada, we're so like about, you know, we don't want the big guy looking at us. Like, we know you're doing this, but this is more about sustaining, evaluating, networking, and building the network, and having a Canadian contingent that, like, literally, I'm not kidding you, when I was at ICN, and I don't know if you ever came by the booth, it was literally like with the killer bees. Like, I was being swarmed 24/7 because we shipped over thousands of pounds of stuff. And you had 8,000 odd people there, of which 5,000 were Spanish and several from the poorer Latin American countries. And for them to have these resources, it was like they were being handed gold. Like, as a matter of fact, we were giving them our pens and stuff. Like, they were just pawing at me. I felt like I was, like, you know, because it was just for them, like, Canada, like, and then our OECD comparator countries were more just having a strategic conversation with us. Because all of us are struggling with the same thing. We know the difference we're making. We know all of your research projects are demonstrating that. But the decision makers and the policy makers are maintaining the status quo. And we have to have that conversation. So, you know, when I told you, like in China, all of a sudden nurses are doing wound care. In Australia, they're demonstrating the research impact and value. And you know where the world's so small? Guess who's now the DM in Adelaide, the province of Adelaide in Australia? And Adelaide became a BP years ago.
So Deputy Minister of Health?
Yeah. Vicky Kaminsky. So the world is freakishly weird in a way, right? That nurses go in all these places, our careers take us. You know, you've got Deb White in Qatar. Who would have imagined a decade ago or whenever you pre-conceptualize that? But so it's how do we share this and help each other and spread? And for me, that's, you know, and some of you that knew me as the senior nursing advisor, like to me, this is the easiest job, helping advancing nursing practice within my own jurisdiction and around the globe. And talking to nurses that actually have tools in their hand to substantiate that we have a knowledge base, which is what's happening in the third world countries.
Well, Valerie, thank you so much for being here today. When I think of the word champion in nursing, I think of Valerie as just a real inspiring change maker in nursing. So we're really fortunate to get you here today, and in the light of all the other travel you're doing especially, but with this to kind of spur our curiosity and help us think about how we might take this forward. So thank you so much.
Thanks, everyone. Thanks.